So let's start at the top of the gastrointestinal tract with GERD. Gastroesophageal reflux, or GERD, was one of the earliest GI conditions to be associated with obesity. It was recognized with rising rates of obesity and also rising rates of esophageal adenocarcinoma. In states of obesity, there's increased adiposity and increased visceral fat that results in a variety of mechanical effects, including the disruption of the GE junction, which leads to a hiatal hernia. There are also transient relaxations of the lower esophageal sphincter and increased gastric pressure, which leads to esophageal reflux. Abdominal adipose tissue also is associated with an increase in circulating pro-inflammatory cytokines, which have been linked to inflammatory processes like erosive esophagitis, Barrett's esophagus, and esophageal adenocarcinoma. Obesity, and specifically abdominal adiposity, has been also linked to inflammatory bowel diseases such as Crohn's disease and ulcerative colitis. Recent studies have linked visceral adiposity, or abdominal fat, to lower rates of clinical and endoscopic remission in patients who are being initiated on biologic therapy, as well as an increased time to flare in patients with inflammatory bowel disease. When you think about malignancies, colon cancer has a strong association with obesity. As you know, colon cancer is the third leading cause of cancer death in the U.S. and has been strongly associated with visceral adiposity. We do see a differential effect in colon cancer with respect to gender, with a greater effect being seen in males versus females. But nonetheless, we know that obesity is associated with the rising rates of colorectal cancer.